Did you know that hypertension is the leading cause of maternal and fetal complications globally? Yet, with the right knowledge, the outcomes can be prevented. In this video, I will teach you on how to recognize, diagnose, and manage hypertension in pregnancy based on the latest medical guidelines. Are you ready? Let's get into it. So, what you need to know in hypertension in pregnancy is that timely action can be the difference between life and death, both for the mother and for the unborn child. And in this channel, we're all about saving lives and making sure that you are equipped to be able to help as many people as you can in your area of practice, as a student, as a medical professional. And I'd like you to subscribe, hit the notification button so that you never miss out on any of the content that I make, and we keep on saving lives. All right, so a few words and terms that you need to know, even as we are going to go into this discussion. Firstly, hypertension. All right, it's coming from two words. There's hyper and there's tension there. The word hyper means over or exaggerated, okay, or excessive. Tension, we're talking about stress. Few basic concepts that you need to understand: blood flows through the blood vessels, and the pressure that the blood exerts on the walls of the blood vessels, whether it's the capillaries, it's the arteries, or the veins, we call that blood pressure. Okay, so we have arterial blood pressure, venous blood pressure, capillary blood pressure. And so if that pressure is excessive, we are calling that hypertension. But we'll go into more of that even as the video goes on. Then you need to know what pregnancy is. This is a time period from conception until birth, okay, which is divided into 3 trimesters. It's a total of about 40 weeks. Okay, that's an important definition. We also need to know what gestational age is. So gestational age, we are talking about the age at which the pregnancy is at every particular time, okay? And this is counted in weeks from the 40 weeks that is expected as the normal, plus or minus 2 weeks. And then another word that you need to understand is age of viability. So age of viability, this is the age or the gestational age at which, if the fetus was to be born, would be able to survive outside the womb. Now, this age of viability is relative and it's subject to the healthcare quality of a particular nation. So, in different parts of the world, for example, in Zambia, the age of viability is 28 weeks. In the USA, the age of viability is 20 weeks. In the UK, the age of viability is 24 weeks. So, based on the NICU services and the different equipment that is needed from the hospital to ensure the survival of the baby or to create a near normal environment, which is like the womb for the fetus, that is what is going to determine what age of viability is. So, what then is hypertension in pregnancy? So, by definition, and this is a complete definition, hypertension in pregnancy, this is a sustained elevated blood pressure of systolic greater than 140, diastolic greater than 90 millimeters of mercury, which is measured on 2 occasions, 4 to 6 hours apart, and it's after 20 weeks of gestational age. So if it is hypertension in pregnancy or pregnancy-induced hypertension, it should be 1, a sustained elevated blood pressure of at least the systolic should be greater than 140, diastolic greater than 90. It should be measured at least on 2 occasions because we know the different factors which can cause the blood pressure to be high or low. For example, if somebody is stressed, if they are from running, all those things can cause an immediate rise in the blood pressure, but it will calm down. So if you measure again after 4 to 6 hours and the blood pressure is still high, then we're saying this is hypertension. And if it occurs after 20 weeks gestational age, we're saying this is hypertension in pregnancy. So how is hypertension in pregnancy classified? So hypertension in pregnancy is classified according to the following. One, there's what we know, or there's what is known as chronic hypertension. So chronic hypertension, by definition, we're saying this is a sustained elevated blood pressure of systolic greater than 140, diastolic greater than 90 millimeters of mercury, measured on 2 occasions, 4 to 6 hours apart, which first appears in pregnancy before the 20 weeks. Okay, first appears in pregnancy before 20 weeks. So if it's there before 20 weeks, we're saying it's chronic hypertension. Most likely the woman had hypertension, okay, but it wasn't managed. Then gestational hypertension is the definition I just gave. This one occurs after 20 weeks gestational age. Then if there's going to be appearance of protein, okay, in the urine, proteinuria, okay, to a sustained elevated blood pressure after 20 weeks, we're going to call that preeclampsia. Preeclampsia. And then if there's going to be an addition of seizures, okay, if there's going to be an addition of seizures, so there's a sustained elevated blood pressure, okay, we have proteinuria plus seizures, we're going to call that eclampsia, okay. And from the Greek origin, the word eclampsia means to seize, okay, or having a seizure. And lastly, we have chronic hypertension with superimposed preeclampsia. So this is where the first appearance of blood pressure happened before 20 weeks, but after 20 weeks, there's an appearance of proteinuria. So we're saying this is chronic hypertension with superimposed preeclampsia. And it's very important to know the different classifications because it will help us in our management. Because at the end of this, ladies and gentlemen, what we want is a mother who is okay and a baby who is okay. Okay? And so knowing the different classes will help us manage the patient properly. Because remember, timely action can be the difference between life and death in this particular case. So what's the main problem in hypertension in pregnancy? How does the pathology affect the physiology and lead to clinical features? Okay, so I want us to look at the pathophysiology of hypertension in pregnancy, specifically preeclampsia, because it justifies why we do what we do and how we manage these particular patients that we have. Okay. So remember, for it to be called preeclampsia, we're saying it should happen after 20 weeks, and there's going to be the appearance of protein in the urine. So now the question is, how does preeclampsia come about? So there's different schools of thought, but the most adopted theory of how preeclampsia comes about is with the failure of the second invasion of the placental blood vessels, okay? Because at around 16 to 18 weeks, there's going to be the first invasion of the placental blood vessels, okay? But by week 20, there should be a second invasion, which means there has to be remodeling, okay? The blood vessels of the placenta and the maternal blood vessels, they remodel in such a way that the blood vessels begin to receive more blood from the mother. All right, so this is where our pathophysiology begins. So there's defective spiral artery remodeling. So normally in pregnancy, the maternal spiral arteries in the uterus undergo a significant remodeling. That means they become wider and they become less resistant to blood flow. This ensures that there is more supply of blood to the placenta. But in preeclampsia, there is failure of that remodeling. So it's either it's incomplete or it's defective. And once that occurs, the arteries remain narrow with high resistance. That means there's going to be a reduced blood flow to the placenta. which causes placental hypoperfusion. Now, when placental hypoperfusion occurs because of the defective remodeling, the placenta begins to incur hypoxic and ischemic injuries. Okay, so there's low oxygen going to the placenta, there's low perfusion, okay, of the blood going to the placenta, which sets off a cascade of events, and ultimately this leads to ischemia and oxidative stress. So this placenta being hypoxic, it's not having enough oxygen, it leads to a generation of excessive reactive oxygen species, okay, which causes oxidative stress. This damage or this oxidative stress leads to damage of placental tissues. It triggers the release of certain harmful substances from the placenta into the maternal circulation. So amongst the things that are released into the maternal circulation, there is what we call, a release of anti-angiogenic factors. For example, there is what is known as soluble FM-like tyrosine kinase 1. There's also soluble endogen. Okay, these, when released, they begin to reduce or they inhibit the pro-angiogenic molecules. Okay, so there's no they begin to inhibit the pro-angiogenic molecules. For example, there's the placental growth factor and the vascular endothelial growth factor. And once these are inhibited or there's an imbalance, it leads to a disruption in the normal functioning of the blood vessels. So these are released into the maternal blood system, and it causes endothelial dysfunction ultimately. So once endothelial dysfunction sets in, what then begins to happen is that, one, there's going to be an increased vascular permeability, which allows the blood vessels to be leaky, which will in turn lead to edema. Okay, sometimes it's just pseudoedema, sometimes it's generalized edema. Okay, if all the blood vessels are involved. Number two, it also leads to proteinuria. Okay, if the glomerular filtration is affected, you'll find that the large molecules which do not usually pass through, like the albumins, they begin to pass through, and we see the presence of that in the urine, which shows that there's increased vascular permeability. Aside from that, there is reduced vasodilation, okay, because of the loss of nitric oxide. So the activity of nitric oxide is impaired, which is going to lead to reduced vasodilation, which in turn causes increased vasoconstriction, which will increase the BP. Because remember, blood pressure, we're saying it's cardiac output multiplied by the total peripheral resistance. So if we cause vasoconstriction, we're going to cause systemic vasoconstriction. Okay, we're going to cause an increase in the total peripheral resistance, which leads to an increased blood pressure. Okay, so once there's systemic vasoconstriction, there's going to be hypertension, plus there's going to be organ injury. Okay, so the key organs that are affected, which show that there is signs of organ injury, number one, there is the kidneys. Okay, so the kidneys, because of the reduced filtration, there's going to be proteinuria. Okay, and there might also be some derangements in the renal function. So if we do a renal function test, we'll find that there's a derangement. Then in the liver, there's microvascular damage, which may lead to HELP syndrome. Okay, HELP syndrome, standing for hemolysis, the H. The EL stands for elevated liver enzymes and low platelets. And then the brain, okay, with increased blood pressure and endothelial damage, it causes neurological symptoms such as headaches, visual disturbances, and seizures, which we are calling eclampsia. So we can see there's edema there, and then there's neurological signs. And I've also described the proteinuria. Some of the other neurological signs, apart from headache and seizures, you can also have blurred vision or scotoma. So you find that there are certain parts of the visual field that the patient is unable to see, which shows you that there is most likely a challenge on the neurological side of things. So now that we know the pathophysiology, we know how this comes about and how some of the clinical features come about. What are some of the signs and symptoms of hypertension and pregnancy? Okay, so these are not all of them, and these are not always present. Okay, the most sure one is an elevated blood pressure. So you will most likely find an elevated blood pressure based on the the millimeters of mercury that you find when you use a sphygmomanometer. So and this elevated blood pressure will also determine the classification. For example, when it comes to preeclampsia, it's divided in two. There's mild and severe. So if it's mild, then it's greater than 140 systolic but less than 160, and diastolic is greater than 90 but less than 110. Then if it's severe, then systolic is greater than 160 and diastolic is greater than 110. All right. Then the patient can also present with severe headaches, as I just explained in the pathophysiology, visual disturbances, and epigastric pain. Okay, the epigastric pain, this is due to an increased pressure. Okay, in there's an increased pressure in the liver capsule. So once there's an increased pressure in the liver capsule, or there's a stretching of the liver capsule, it causes referred pain from the right upper quadrant to the epigastrium. Okay, and so there's also proteinuria and signs of end organ damage like visual disturbance, headaches, and the other things that we've discussed already. There's also fetal growth restriction. Remember, the growth of the fetus is dependent on receiving oxygen and nutrients from the mother through the placenta. But if there's reduced placental supply, okay, of oxygen and nutrients, there's going to be fetal restriction. Then plus or minus edema. Again, we mentioned that there's going to be leaky blood vessels. Also, in addition to the leaky blood vessels, because we are losing proteins, especially if there's proteinuria. Remember, part of what keeps the fluid component of the blood in the blood circulation is oncotic pressure. But then if we're losing albumin, we end up losing the fluid. Okay, so there's going to be edema. So now that we know the symptoms and the signs of hypertension, and you are able to recognize that this is hypertension in pregnancy and classify it, how do you investigate? What is our focus of investigation? Okay, what do we focus on when we are investigating hypertension in pregnancy? So specifically, okay, when it comes to investigation, the two things that we want to do is, one, confirm the diagnosis. Two, want to assess for severity. Okay, confirm the diagnosis and assess severity. Remember, what's the one thing that you can do to be able to confirm that this is preeclampsia? Once you find there's an elevated blood pressure after 20 weeks, you want to do a urinalysis. Once you do a urinalysis, what you want to look at is the protein. Okay, is there proteinuria? One, we can do spot urine. So on the stick, it will be plus or minus. Okay, so anything greater than +1 is proteinuria, or we can do 24-hour urine collection, and if it's greater than 30 milligrams, okay, then we are saying this is preeclampsia. Another thing that you can do to assess severity, okay, one, we're going to do the LFTs. Remember, if the liver is involved, there's going to be a derangement in AST and ALT. We want to do our full blood count, and what we're looking for is the HB, because there's going to be hemolysis if there's HELP syndrome. Okay, we're assessing severity. We also want to do renal function tests like urea and creatinine. Okay, again, we want to assess if the kidneys have been involved. And lastly, on the full blood count, we also want to look at the platelets to also assess for the HELP syndrome. Then we can also do a fetal assessment. Okay, we can use an ultrasound scan to be able to look at the growth of the baby. Remember, there's fetal growth restriction. Then we can also put the lady on CTG, okay, just to make sure that there's no fetal distress, because one of the conditions which predispose or which can lead to fetal distress is hypertension in pregnancy, especially severe preeclampsia. So now that we're able to investigate, we're able to confirm, and we're also able to assess the severity, how do we help our patients? A woman comes to you, she's G2 para 1, she's at 28 weeks of pregnancy, she has a BP of 160 over 110 with protein in the urine. What are you going to do? How are you going to help this patient? You've done your investigations, you've done your urinalysis, you've sent blood for LFT, RIFTs, and full blood count. The woman is on CTG, you're looking at the fetal heart. How do we manage this patient? So our management is going to be, so we're going to discuss the management plan based on the gestational age and severity. Okay, so remember, there will be the general things that you can do, okay, in every case. Then we have a woman with an age of viability, okay, like a pregnancy which is less than the age of viability based on the country that you're in. A woman whose pregnancy is above the age of viability but before 34 weeks, and a woman whose pregnancy is after 34 weeks. Okay, so we're going to start with a stable patient. So if you have a stable patient, in this case, we're saying the blood pressure is anywhere between 140 to 145, 90 to 95, okay, with no signs of severe symptoms, okay, of hypertension in pregnancy. What you want to do is we're going to start this patient on antihypertensives, okay, to control the BP. We're going to do a BP profile, okay. We're going to do a BP profile. This is the general thing that you do with all the patients that come, whether they are stable, want to put them on antihypertensives, do a BP profile. Some of the antihypertensives that we can give which are safe in pregnancy, we have lobetalol, methyl dopa, nifedipine, okay, low dose ASA, okay, or aspirin. Just type in the comment if you would like me to make a separate video where I explain the mechanism of action, the doses that we give in those different antihypertensives. But so far, I just like to focus on the general management of this woman in hypertension, with hypertension in pregnancy. So if the patient's age of pregnancy is less than the age of viability, okay, we can manage the patient as an outpatient. Remember, this is a stable patient. If they live near the hospital, we can manage them as an outpatient, and we see them bi-weekly in antenatal visits, and want to do close monitoring, okay, and make sure that the patient is adherent to the drugs, and they can share with us. Want to monitor any changes in, one, the blood pressure, and two, if there's any appearance of urinalysis. So with every visit, you'll be doing urinalysis on your patient. If the pregnancy is above the age of viability but less than 34 weeks, we would like to give corticosteroids to make sure that there's lung maturity. Okay, so we can give dexamethasone or betamethasone, and want to do conservative management. Okay, so remember, this is a stable patient. So conservative management, we're seeing them bi-weekly, and once they hit 30 weeks, we see them every week. Okay, and if there's any changes, we can deliver the fetus. If the patient is stable, fetus is above 34 weeks, everything is okay on the ultrasound scan, then there's no reason to wait. Okay, you can still go for the conservative management, but you can still deliver the baby at 34 weeks. Yeah. Then if there's mild preeclampsia, okay, general things that we do, again, antihypertensives, BP profile, conservative management with close monitoring. Okay, so again, we can still manage this patient as an outpatient. Here we're saying they have a BP of 150 over 100, okay, somewhere around there. It's below 160. We can, based on the condition of the patient, we can manage them as an outpatient, or we can hospitalize and for close monitoring. Okay, if the pregnancy is above the age of viability but before 34 weeks, what we want to do is give corticosteroids, betamethasone or dexamethasone. We want to do an ultrasound scan to assess, want to do our biophysical profile of the baby. And if everything's okay and we notice that there's changes in the pattern, for example, on one day it's 160, then it goes back to 150, 145, we may still want to deliver the baby then. If the pregnancy is above 34 weeks, deliver the fetus. Severe preeclampsia, okay? In severe preeclampsia, we want to do our antihypertensives to control the BP profile, okay, to monitor the changes in blood pressure. We want to give magnesium sulfate, okay, as prophylaxis to prevent eclampsia, okay, to prevent eclampsia. When I make the video, which you guys will suggest to me, I'll be able to explain to you the doses and how it works. Okay, all severe cases of preeclampsia, we hospitalize the patient. So we admit the patient, do the investigations, and we want to do the LFTs, want to do the renal function tests, HELP syndrome, want to look for that. If there are signs of compromise to the mother, then you'll find that the pregnancy is more harmful than it is helpful, or the pregnancy is more harmful to the mother, we may consider a termination of pregnancy. But that's in discussion with the parents, okay, the mother. If the pregnancy is above the age of viability but less than 34 weeks, we want to give dexamethasone, okay, as well as give everything else, okay. So if you notice the way this discussion is, it's based on it's in addition to everything else that you've done. So you still do magnesium, you still give antihypertensive, you still hospitalize, you still investigate. If it's above the age of viability and the weight is okay, based on what the hospital can handle, give this dexamethasone, deliver the fetus, okay. If you've stabilized the BP, want to deliver in the quickest way possible, we may choose to do a cesarean section if there's fetal compromise, or we do induction of labor. Okay, if it's above 34 weeks, deliver the fetus. Lastly, if there's eclampsia, okay, the patient has feted, what we want to do is want to give diazepam, okay, to abort the seizure, and also want to give a maintenance dose for diazepam, okay, to make sure that the patient does not seize again. Then we want to give magnesium sulfate to prevent another seizure. We give antihypertensives to control the BP. Okay, if the pregnancy is less than the age of viability, then we can do what is called a medical termination of pregnancy. Okay, because now it's affecting the brain, and so the woman remaining pregnant will be more harmful than helpful to her. Ultimately, the management for preeclampsia is we deliver the fetus in spite of the gestational age. So if it's above the age of viability, less than 34 weeks, you may still want to give DEXA, but ultimately we want to deliver the fetus. Why? Because the one organ which is foreign in this case is the placenta. And so the main management is to remove the placenta. And we cannot remove the placenta unless we deliver the mother. So what would happen if timely action is not taken? After everything that you've learned, if timely action is not taken, what can happen to the mother? What can happen to the fetus? So we are dividing complications into maternal and fetal complications. There are many more complications. I'd like you to type them in the comment section. What are some of the complications that I have not listed? There are many more, but I wanted to just share with you the most important one. We have HELP syndrome. Okay, there's hemolysis due to the endothelial damage and the reduced the narrowing of the blood vessels. Okay, the red blood cells undergo shearing, and there's hemolysis in this case. And then there's elevated liver enzymes because of damage to the liver due to hypoperfusion. The liver cells get damaged and they release their enzymes, the LST, ALT. And then there's also low platelets because there's widespread endothelial damage. The platelets are consumed. They go and try to stop the damage that is occurring. Therefore, there's reduced amount of platelets in the blood. Okay, if not, if timely action is not taken, it can lead to the seizures. Okay, that means once the patient had severe preeclampsia, we never gave magnesium sulfate. We didn't try to prevent these seizures. Okay, then it can also lead to a placental abruption because of the reduced, again, the narrowing maternal blood vessels. Okay, so the placenta can detach before time, okay, which is an emergency. And then there's also multi-organ damage. Okay, the liver, the kidneys, the brain. On the fetal side, there's growth restriction. Okay, there's preterm birth. Okay, you'll notice that we're not even talking about 37 weeks. We kept on saying above 34 weeks, deliver the fetus. Above age of viability, before 34 weeks, give DEXA, deliver the fetus. So it predisposes, or it's a risk factor for preterm labor. Okay, it's also a risk factor for fetal distress because of the hypoxia, or the hypoxic insult to the placenta, which in turn reduces the delivery of the oxygen and the nutrients to the fetus. It can also lead to an IUFD, okay, intrauterine fetal death, which would be a stillbirth if timely action is not taken. So remember, ladies and gentlemen, today we've explored the Today we have explored hypertension in pregnancy, covering the types, pathophysiology, clinical features, investigations, and management. And remember that the timely action can be the difference between life and death. So empower yourself with this knowledge. Take immediate steps to apply it. More tips. For more tips, I'd like you to download the study songs that we have made on our other channel called More Music Notes, which has to do with every segment of this particular lesson. Okay, I'd like you to subscribe. I'd like you to hit the notification and make sure that these concepts remain fresh in your head. Let's go and save lives, ladies and gentlemen. Until the next video, it's bye bye for now.